presentation to be with you today. I am just going to take 2 seconds because I believe I've got the wrong presentation up. I'll end that one. And I think I'm meant to be talking about the Sentinel cerebral embolic protection first. Sorry about that. So, cerebral embolic protection. So why wouldn't you, I suppose, is the question that I would pose at the beginning of this. And hopefully by the end of this presentation, everyone will be on board with the similar thought process about why wouldn't you do this. Having just listened to the last presentation, I suppose one issue would be that this does mean that we're going to be using the right radial artery, and we may have to then again rethink about what that second access point is and whether that becomes the left radial, or whether everyone believes in this technology enough to go back to using the femoral artery for the alternate access. So one thing that when we talk about this is common is people start to think, well, stroke is going down. Is it really still an issue? But it is, and we know stroke remains an important complication of cardiac interventional procedures, and particularly in TAVI. And the reported stroke rate still around that 2 to 4%. But even that is likely to be an underestimation of the real rate of stroke. And that's because we've got different definitions and different methods of trying to elicit stroke. So if we have an independent neurologist looking for the stroke as opposed to the cardiology unit coming past on their ward round, then those stroke rates change. And in fact, in a lot of the cerebral embolic protection trials where there is an independent neurologist, the rate of stroke is approaching 10%, if not higher. But in addition to that 10%, we know that if we actually image and look for cerebral insult with an MRI, we see diffusion-weighted imaging lesions in nearly 100% of patients. And while we'll often use the term silent infarction in these instances, there's also a push to as to whether silent infarcts really have no clinical impact at all. But rather, do they also have an impact on subtle neurocognitive changes? And are those neurocognitive changes really benign, particularly as we move towards lower risk patients being treated with this technology? And is that going to impact their quality of life and their ability to sustain independent living into the future? Or does this put them behind the 8 ball as far as future cognitive issues? As far as the timing of stroke, we know that the majority of stroke is periprocedural, happening within that first 24 hours. But we also see quite a significant number within the first 3 days. And some of this is likely to be actually unrecognised procedural stroke. Patients are either in some institutions still having general anaesthesia, which delays the recognition of the stroke, or even when they're done under sedation, that sedation wearing off and people feeling that those initial changes are due to sedation or delirium, delaying that incidence or delaying that early recognition. So we also know quite a lot from these cerebral embolic protection trials about what causes stroke during these procedures. And we can find debris captured in these filters in nearly 100% of patients following a TAVI. The debris includes a range of things that we would have thought of, like thrombus, but also things that we didn't really think would be in these baskets. Not only valve tissue, but also myocardium, plastic and foreign material. And in fact, nearly half of patients have at least one particle that's greater than 1 millimeter in diameter. So pretty big amounts of debris that can cause quite significant impact to the cerebral circulation. So still, I'm sure there's people in the audience and people in my own hospital that would argue that really I don't see a lot of stroke. It's not a problem for me. It might be in these registries, it might be in these randomized trials, but surely stroke rates are coming down. Well, if we look through the TVT registry, and this is kind of pre-COVID data now, but we didn't see stroke rates coming down. They maintained at these levels. And again, this is a TVT self-reported registry. So we're seeing those lower rates of stroke in around the 2 to 3%, recognizing that there'll be a lot of unrecognized stroke above this that would put this back into those same percentages. But really from 2012, in that 5-year period, no reduction in the rate of stroke. Other people would say, but I use these new generation devices and wires, and so surely the rates of stroke are coming down. Well, again, here we can see that new generation devices compared with early generation devices, no statistically significant reduction in the rate of stroke. And then there'll be others who say, yes, but these are because there's a whole heap of low volume operators out there who are on the learning curve. They're only doing a small number of procedures. And I do a high volume operator at a high volume center. I don't see the same number of strokes. But again, out of the TVT registry, we can see as far as most other complications, that's true. Our mortality is better, our bleeding is better, our vascular injury is better if we're a high volume operator at a high volume center. But highlighted in the red square there on the bottom right, we can see this doesn't pertain to stroke. High volume centers, high volume operators still have a same percentage of stroke cases. So this isn't an issue that's going away. Some people might be out there saying, but I use solely Edwards, I use solely Medtronic, and this is a slightly old slide, so it also has the Lotus device in it. But we can see the rate of stroke is similar in all of these cases, and the risk reduction by using cerebral embolic protection is similar across the device types. So how can we reduce TAVI-related stroke? Cerebral embolic protection devices. And while many have come, and some of these are still under investigation, the one device that has, in most markets, reached clinical use is the Sentinel embolic protection device. And this is now owned by Boston Scientific. So this includes two independent filters to capture, but not only capture, also remove the embolic materia. So as opposed to deflection devices that sit in the aorta and send the debris downstream into the lower circulation, this actually captures and removes that debris. There are two filters. They have a pore size of 140 microns, and it's inserted via a generally right radial approach, and if that's not feasible, via a right brachial approach. Has the two filters, one that sits in the innominate vessel or the brachiocephalic, and then a deflectable tip that allows cannulation and insertion of the distal filter into the left common carotid artery. This device was initially investigated in the Clean TAVI study. So this was only 100 patients randomized to have the device or not. This was not powered to show a clinical difference, but did show a reduction in the number and volume of lesions on MRI if patients had the device implanted. Most of the rest of the data until some upcoming trials has been from independent single center registries, but they've been showing remarkably similar results. So the relative risk reduction for stroke across three large centers, Ulm, Cedars-Sinai, and Erasmus, have all shown roughly a 70 to 80% relative risk reduction in the rate of stroke. So very consistent results. The US IDE trial was also reported a few years ago now, and it took the patients into either a control arm to not have the device, an imaging arm who had the device and followed up with with MRI imaging, and a safety arm who didn't have the MRI but looking for any safety cost of using this device via the radial artery. And it was a negative trial. So as far as its primary endpoint, there was no statistically significant reduction in 30-day MACE rates. But when on post hoc analysis, on the pre-specified look at 72 hours, again, we see this 63% relative risk reduction in the rate of stroke. And you could argue that really these are the strokes that we think we're going to prevent, is those at the time of the procedure. If we look at a 30-day outcome, we start to cloud the results here with things that are unrelated to the procedure, and we're never going to be reduced by putting a device in only for the time of the procedure. We also got from this trial that it's a very safe thing to do. It added on average 4 minutes to the procedure time. There was no significant increase in contrast use, and 99.6% safe and successful delivery and retrieval. Those extra 0.4% were access-related hematomas, so also things that were easily managed. So a very safe thing to do for a likely 2/3 relative risk reduction in the rate of stroke. So what does this look like? And hopefully some people are already using this, but this is actually a slightly old case again. You'll see when you see the valve type that was used in this case. But a 76-year-old female with symptomatic severe tri-leaflet aortic stenosis, no history of stroke, moderately calcified aortic annulus, but was the primary caregiver for her disabled husband. So there's nothing here other than being female, which we know is associated with a high risk of stroke, that really jumps out of us. It's not a valve-in valve, it's not a bicuspid valve, none of those other risk factors for stroke in this case. And so this will come to one of the other questions I would pose later, but if we're not going to use it in everyone who does get this device, and you could have said this lady doesn't, but if she suffers a stroke and she's the primary caregiver for her disabled husband, then we have two people who are going to end up in care facilities. So a major impact. So hopefully this plays, but this is showing a standard sentinel deployment. So generally we've got an aortogram first that shows us where we're going to have deployed our device. Initially come down via the radial approach over an 014 wire, and we have a little puff of contrast that's going to show us where to deploy this filter so that we're still below the vertebral artery on the right-hand side. We deflect the tip and we use the wire to wire the left common carotid. We pull up onto the arch and then we push forward to deploy that left common carotid filter, and the device is implanted. So you can imagine how we're able to get that 4-minute deployment. You can position the device in different ways during. You can leave the arm out to the side, or you can bring it in adjacent to the patient during the procedure. And sorry, won't let that replay. Here you can see why this is an old case, because traversing here you can see the Lotus Edge device, really here just to highlight that lack of interaction between the TAVI device coming across the arch and the device sitting nicely up in the roof of the arch. I won't go through the whole deployment for the sake of time. For those who miss Lotus Edge, you can see a very nice Lotus Edge valve in the historical note. And then I will let you see how quickly we can recapture the Sentinel device here, which is really just reversing those steps. So catching the distal filter, advancing out of the common carotid, advancing the device, and then pulling back on the filter. And that was actually not a sped up video. And this is probably what we see in the majority of cases, is that sand-like debris, which some would look at and think, oh, that's a bit underwhelming. But really, I prefer to have that in a basket on the table than in my brain. Sorry, again, I'll just make that move on. Hopefully. Okay. And so again, for the sake of time, very briefly, seeing a device being implanted here, proximal filter in position, coming up, flexing the tip, wiring, pulling up onto the arch, and then advancing the distal filter. Here, a Edwards valve traversing with no interaction between that and the Sentinel device, and then recapture of the device. Again, very simple, straightforward of capturing those filters coming out of the common carotid, straightening the device, and then recapturing the proximal filter and taking all of that debris with us rather than leaving it behind or sending it downstream, as per some of the deflection devices, where of course some of that stuff is going to end up in the kidneys and in the gut and trashing the legs. Here, slightly more impressive, you can see a red thrombus. This was actually sent off to pathology, and the green arrow there actually highlighting a little bit of a leaflet material that had come off during the procedure. So do we need more evidence before we start to use this routinely? Well, that is coming. We have the protected TAVR trial, which was a randomized trial in relatively all comers, and looking at that 72-hour endpoint. That's completed enrollment. We were lucky enough to participate in that trial and is due to report at TCT this year. And a very similar trial that's running in England with investigator-initiated trial, again, randomizing patients to have the device or not, and looking at over 7,000 people in that trial. And there's already pre-specified review that will do a review of both of those trials together. So in conclusion, stroke remains a common and devastating complication of TAVR. Stroke impacts mortality and morbidity and carries a significant financial, physical, psychological, and societal impact. Cerebral embolic protection appears to reduce the incidence of clinical stroke by approximately 75% relative risk reduction, and it's a safe technology with no increase in adverse event rates and no increase in procedural duration. So back to my initial question, why wouldn't you use it? Thank you. So,
yeah, Dr. Robert Gooley,
yes.
do you have another lecture? So
I do.
Yeah. So
let me
just continue the next lecture, and if possible, I think you had better finish within 10 minutes. Then
10 minutes.
we have
Perfect.
we have some time to discuss for the topics.
Let me change over. It's wanting to show you the same one again. Here we go. So next topic is accurate Neo2, which again, hopefully some people have had the advantage of using, and I'll try and whip through this a bit quicker. So the design features, this is the valve. It's a supraannular TAVI valve. It has this upper crown and lower crown, which help to engage the annulus, and a paravalvular leak mitigation system with this skirt around the outside. It has a bit of a marker there to help us position during deployment. As opposed to accurate Neo, the original design, we have an expanded skirt here to help reduce that paravalvular leak. This has that marker to help us also position the device very accurately. And so here we're aiming for not quite as shallow as a deployment as many other devices. One of the significant advantages of the accurate valve is a very low pacemaker rate. And as such, we actually aim to put this in at approximately 6 millimeter depth. And that gives us that maximal radial force at that position. But it also helps to bring those native leaflets down under the upper crown and maintain coronary access, which is one of the distinct advantages. Some of the other changes, as I mentioned, the radio-opaque marker. This is implanted via a 14 French expandable proprietary sheath with the eye sleeve, and it has a new tip and flexible end to the delivery system to aid a deployment into even a very horizontal aorta or a vertical valve lie. Some of the advantages here are that we have these upper crowns and stabilization arches that as those are deployed, we still maintain leaflet function in the native valve. So we have no period of requiring rapid pacing and no period of hemodynamic instability. And then after that's achieved, we then have this very rapid release of the last phase. So no obstruction to outflow at all. At present, on the left of the slide, we have accurate Neo2. It comes in a small, medium, and large device, allowing us to treat annuli between approximately 21 and 27 millimeters. I was actually lucky to run the Accurate Prime XL trial, which is going to see expansion into a new XL device that's completed enrollment. So that'll expand us up to 29 millimeters. And there's a future platform looking at changes again to continue that low PVL rates and improve the procedural ease with things such as commissural alignment. So here's a case example. This patient, annulus-wise, perimeter derived of 26.2 millimeters, very similar dimensions in the LVOT, tri-leaflet valve, and decent sinus capacity. So the plan here for a right femoral approach using the 14 French eye sleeve. One of the things that we have moved towards, and you'll see in some of the evidence coming up, is a significant pre-dilatation. So here a 25 millimeter pre-dilatation, and then placing the large accurate neo. So you can see the initial aortogram, and then you can see that 25 millimeter full-size BAV performed here. We tend to use a true balloon, so a very non-compliant balloon. So the device is inserted, as we said, through that sheath here over a Safari guide wire. So it expands the sheath as it comes up, and then on the right-hand side, you can see as it comes through the end of that sheath, you can see that expanding. Tracks really nicely over the wire and is very flexible up through the arch with very minimal interaction. And then the aim is to deploy this and to bring it down on the greater curvature so that that marker just approaches the annulus. And we do this very gently. We don't want to end up too deep. And we're really aiming to have that marker sit nicely on the annular plane. That sets us up for success here, where we're going to end up with that exact 6 millimeter depth. It's a top-down deployment. So you can see on the left here, the first stage is the release of what we call those upper crowns, which are going to sit over the top of the native leaflets and help capture and push those down. And then the next step is release of those stabilization arches in the aorta, which helps to keep us coaxial. And then we have the final release of the device, so we confirm that we're in the right position. It hasn't moved, the marker's still sitting nicely on the annular plane. And then you'll see here a very swift release. What I haven't gone through here is also the ability to achieve commissural alignment by knowing where those 3 posts of the device are sitting. And here you can see the 1 post out on the greater curve, 2 on the inner aspect, telling us that we are going to have achieved commissural alignment. Finally, device in position and the final aortogram. Still here with a stiff wire across, but you can see a very nice, removing the device first, and then I will show you the final aortogram, showing that 6 millimeter depth, no coronary obstruction, and really pushing those native leaflets down under the native coronaries. So clinical data-wise, as far as the NEO2, we have early NEO2 registry data in over 500 patients, showing very little paravalvular leak. So again, similar to other devices on the market, 1.3% greater than mild paravalvular leak, very low gradients. It's a supraannular valve, so 9 millimeter post-procedural echo gradient, and very low pacemaker rates in a real-world registry of 6% here. So really class-leading pacemaker rates. If we then look at a matched comparison between NEO and NEO2 in the same cohort, we can see significantly lower amounts of regurgitation compared to the original NEO valve. A similar registry out of Italy here, leading to NEO versus NEO2 in matched comparison. You can see a very well-matched cohort here, and very similar baseline conduction abnormalities. And you can see we now move towards more pre-dilatation and less post-dilatation with NEO2, but lower procedural duration, lower use of contrast. And you can see much higher technical success of 97.6. So VARC2 here, suggesting that we're not getting gradients of over 20, we're not getting moderate PVL. So very high procedural success and very low pacemaker rates in this registry of around 7%. We maintain that hemodynamic compared to NEO, and we've got much less paravalvular leak. We also have some head-to-head data coming out with matched comparison to SAPIEN Ultra. You can see we have much lower gradients at the end of this. So an average of 9 millimeters of mercury compared to 34 millimeters of mercury with Ultra. Sorry, percentage of patients. Here, 9.8% of patients having greater than 20, 2.6% having greater than 20 with NEO2, and much lower rates of patient prosthesis mismatch. So very important, particularly in patients who are going to have a small annular area to begin with. You can see here we're matching Ultra as far as less than mild paravalvular regurgitation. In fact, we've got less. And over on the right-hand side, you can see a significant difference with those gradients. So it is statistically significant as far as the lower gradients. We also have the Common Line trial, which has come out of Lars Sondergaard's group, single center trial here, but showing in valves that tell us that we are able to achieve commissural alignment, that we don't always do it. So with Evolute, in 10% of patients, we still have moderate or severe misalignment. With Portico, a quarter of patients still misaligned. With Accurate Neo, no patients misaligned. And then that leads to the improved ability to re-access the coronaries. So here out of Catania in Italy, Marco Babanti's group, 100% of patients treated with the Accurate Neo, they were able to get back into the coronary and re-access, as opposed to only 82% with Evolute R and 99% with Sapien. I won't go through any of this, but this is still enrolling in the US, which will compare Accurate Neo 2 to other commercially available devices. That's, I think, about 2/3 enrolled. And as I mentioned, I was lucky to be the PI on the Accurate Prime XL, which has completed enrollment and will see expansion into the 29mm valve system. So in conclusion, the Accurate Neo 2 incorporates new skirt technology that actively seals and prevents PVL. The initial clinical experience is fantastic. It has design features that may actually offer advantages over other currently available devices, and hopefully we'll be able to confirm those findings in the Accurate IDE trial. Thank you.